The spectrum of acute myeloid leukemia hovers from de novo acute myeloid leukemia, that is patients who have not had a prior diagnostic of other myeloid neoplasms or therapy for other cancers, to patients who have had prior history of some other myeloid neoplasms like myelodysplastic syndrome, chronic myelomonocytic leukemia, and then they develop an AML, which is also known as a secondary AML. In this group of clinically secondary AML, which have traditionally known to be an adverse risk feature irrespective of genomics, some patients could progress from MDS or sAML directly to AML without having received treatment for the antecedent myeloid disorders. They are known as untreated secondary AML, where some patients could have got treated for their MDS and sAML with hypomethylating agents or transplant, and then proceed to an acute myeloid leukemia, which is known as treated secondary AML. Traditionally treated secondary AML have still been considered as newly diagnosed AML, which means that the expectation of patients and physicians for their outcomes should have been like what a newly diagnosed AML would lead to. Here, we focus on 673 patients with treated secondary AML. That means these patients had a prior diagnosis of MDS or sAML and had received hypomethylating agent or chemotherapy or allogeneic stem cell transplantation and then developed an AML. In the overall cohort, we see very dismal relapse-free survival and overall survival short than 6 months. And even an otherwise favorable group of patients, that means patients without complex cytogenetics or patients without a TP53 mutation, where we would expect median survival upwards of 18 months or 24 months, we see the median survival trail between 9 to 12 months. What we try to show from this data set is that patients with treated secondary AML as a group have inferior outcomes irrespective of their underlying genomics, and they should be considered more in line with relapsed refractory leukemia, and thus the prognosis of these patients should be counseled according to these outcomes and not like traditional newly diagnosed AML. This also calls for drug development specifically in this space, which have been challenging because the outcomes of these patients have been poor, and also these outcomes mimic that of patients with TP53 mutated AML or relapsed refractory AML. With our analysis, we try to propose that treated secondary AML should be considered an independent adverse prognostic risk, even if they have favorable risk features, which is rare, but nonetheless they fare poorly.